right, so for the second video in the endocrinology PANCE series, again, always following the NCCPA blueprint, I thought I'd dedicate an entire video to just diabetes because it's a pretty big one in endocrinology, and it's something that you'll definitely be tested on, so I feel like it's important to have its own video. So first thing that we'll start with is type 1 diabetes. Of the two, type 1 and type 2, you're definitely going to be tested much more in type 2. Simply because it's much more common and there's a lot more to it. There's a lot more medications and a lot of things that you need to know with type 2 rather than type 1. But I will go over some of the basics with type 1 diabetes. I just don't think it's as important. So type 1 diabetes is caused by pancreatic beta cell destruction. Pancreas is no longer making any insulin at all once you get into the final stages of type 1. Initially, there is the honeymoon period where the pancreas is still producing some insulin, but eventually type 1 diabetic is completely absent of all endogenous insulin. So most patients are usually under 30 years of age at time of diagnosis. Not always the case, but majority of the time. As far as the causes, there's two different types. There's type 1A, which is by far the most common. This is going to be an autoimmune cause. And again, it's the most common type, most common etiology for type 1 diabetes. In these patients, you're going to see what's called GAD antibodies, islet cell antibodies. These antibodies aren't going to be present in most patients with type 2 diabetes, and also in type 1B, which is the non-autoimmune beta cell destruction form of type 1 diabetes. This one is not as common. It's idiopathic, and this one has a much stronger hereditary component compared to type 1, where a lot of type 1 diabetics with autoimmune type 1 diabetes have no other family members with type 1 diabetes, but type 1B does carry a stronger hereditary component. As far as the patient presentation, you should remember the 3 Ps, and those are polyuria, polydipsia, polyphagia. And that's the patient's going to be urinating frequently. They're going to be extremely thirsty because the body's flushing out all of the sugar through the kidneys, bringing with it water. And then they're going to be hungry. And the reason there's excessive hunger, they're going to be eating so frequently is because the way to think about it is they're basically starving in the land of plenty, is the way I've heard it called before. The body has all this glucose floating around, but none of it is able to get into the cells because it doesn't have the insulin. So the person is essentially starving. The cells are starving. So the body thinks it's starving, and they're extremely hungry, and they're going to be eating a lot. In most cases, if their blood sugar gets really high, they're going to be nauseous, and that may not be the case. But the 3 Ps you should remember for the presentation, the most common are going to be the polyuria and polydipsia, and that's how most type 1 diabetics are found initially before being diagnosed. DKA is also a possibility if the blood sugar gets high enough. As far as diagnosis, this is going to be the same for type 1 and type 2 diabetes. You need any one of these to diagnose a patient with diabetes. So you either have fasting plasma glucose of 126 or higher on 2 separate occasions, a 2-hour glucose tolerance test showing a blood sugar of 200 or higher, an A1C of 6.5 or higher, and then finally a random blood glucose of 200 or higher in a symptomatic patient. So in a patient with polyuria, polydipsia, etc., with a blood sugar 200 or higher. So definitely remember these. This is going to be important. And remember, you only need one of these to make the actual diagnosis. And again, this is just diagnosing diabetes in general, not specifically type 1 or type 2. That's where you get into the autoantibodies and things like that to make that specific diagnosis. Also the age and things like that. So other factors go into it. But either type 1 or type 2 can both be diagnosed with these components. Another thing, as far as treatment, I don't think treatment's very important to know in real life, of course, but for the PANCE and for your exams, your EORs, the types of insulin is not that important. I'm going to briefly go over each one just so you have a general idea, but I would not waste time knowing this one has an onset of this long, it has a half-life of this long. I think you should just know a couple of the fast-acting and the basal or the long-acting insulins, and I think that should be enough for the exam. As far as the fast-acting insulin, the most common ones are Lispro and Aspart. That's Humalog and Novolog. Those have a 5 to 15 minute onset. That's going to be your mealtime insulin. Those are going to be the fast-acting ones. There's intermediate that's not used as often. Really, it's a cost issue for most patients. You'll see patients using NPH, and this one has about a 2-hour onset, and it lasts a little bit longer. It can last up to 8 hours. And then finally, your long-acting, your basal insulins. These are going to be Detamir, Glargine, and another one is Degludec, and that's Lantus. Traceba. Those are all the brand names for those, but those are going to be your 12 to 24-hour insulin. Again, do not waste too much time on this. You're not going to get a question asking you how long it lasts. You might get a question. I would think the most you might get asked is maybe if you wanted to give this patient a fast-acting insulin or something like that in the vignette. So just kind of know your fast-actings and your long-acting, your basal. That's as far as I would go with that. Don't worry about the length, and this one's 8 hours, this one's 6 hours. Don't waste time on that. You're going to lose studying for more important things. So another thing that I wanted to mention, you can see this in type 1 or type 2, but it's more common in type 1. And it's something that I remember being tested on. So I think it's important just to get a general idea of what these both are. So there's two different phenomena seen in diabetics. There's Somogyi and there's Dawn phenomenon. Somogyi is basically a patient that has either too much insulin, they didn't eat a snack, they missed a meal at night, so their blood sugar goes low overnight, and then the body, trying to compensate for that low blood sugar, releases a bunch of hormones, cortisol, trying to bring the blood sugar back up, and it's basically in a fight or flight mode because of this low blood sugar. And all of those hormones, what happens is when they wake up, they eat something, to compensate for the low. Now they have all of this insulin resistance in the body. They give insulin for breakfast and their blood sugar just goes extremely high. So all you really need to know about this is it's going to be an overnight low blood sugar followed by rebound hyperglycemia. And the way you're going to treat it is basically just prevent the low blood sugar from happening. So you're either lowering their nighttime insulin, having them have a snack before bedtime. But remember, Somogyi, the way I've seen it, for some people to remember it, is so much or so moch insulin, M-O-C-H, so much insulin, and Dawn phenomenon. People remember that by down insulin, because down insulin is actually when the blood sugar is normal overnight. Same thing though, you have an overnight surge of hormones. This happens in everybody. And these hormones, when you're fasting, again, is another way that your body compensates, because in the fasting state, to try to get the liver to pump out and go through gluconeogenesis. And then what happens in the morning is you have this hyperglycemia from the overnight fast that you had. The way you're treating this is going to be, if they're on a pump, you can increase the basal rate, increase the nighttime insulin. There's a few things you could do. Again, I'm spending a lot of time on this, but I wouldn't go crazy. Just remember, Somogyi is basically a overnight low followed by a rebound hyperglycemia. Dawn phenomenon is a normal blood sugar overnight, but then you have a spike in the morning hours due to the surge of hormones. I just wanted to mention those. So moving on, so type 2 diabetes, this is going to be what you should focus on. This is going to be where most of your questions are going to come from, and this is the more important of the two. So a lot of the things, there's a lot of overlap here. So with type 2 diabetes, it's insulin resistant combined with impaired insulin secretion. These patients are still producing insulin, but they have a resistance, and that's one of the most important things to know. So as far as risks, obesity is by far your greatest risk factor. Not up to 90% of type 2 diabetics are overweight. So this is by far the number one risk factor for type 2 diabetes. And then also type 2 diabetes carries a much stronger genetic component than type 1 diabetes. I work in endocrinology, and actually when we see a new type 2 diabetic, if they don't have any family history of type 2 diabetes, we actually investigate a little bit further just to make sure that there's not another cause for the type 2 diabetes, because in most cases it is genetic. So we'll look for like hemochromatosis, Cushing's, etc., just to make sure that there's not another cause, again, because there is such a strong genetic component with this. So as far as the presentation, it's going to be similar to type 1 diabetes. Sometimes it can be asymptomatic, but again, polyuria, polydipsia, polyphagia, a lot of overlap here. They may have poor wound healing, yeast infections, UTIs, because again, these patients are going to be, it's a more insidious onset compared with type 1, which can be a much more acute onset. So these patients may have had it years before they realize, so their body's already starting to have some side effects. So they may present with some of these things like poor wound healing, UTIs, because of all the sugar in the urine, and other more progressive things. As far as treatment, I'm not going to go into all the medications. I'm going to make a separate video, because this is a pretty, there's a lot of medications that I think I should dedicate more time to that, and I'll give you some ways to remember those. But in the next video, I'm going to go over all the meds. We'll go through all the classes and really break that down. But right now, I think you should just know the basics. Initially, all patients you're going to try lifestyle changes first before you start meds, unless the patient has an A1C of like 10 or 11, they're, you know, losing weight, they have all these symptoms. Otherwise, lifestyle changes before starting meds. And then after lifestyle changes, it's almost always metformin. It's not that way in practice, but as far as the boards are concerned in your exams, after lifestyle changes, metformin is going to be your first line. And then there's a lot of other classes to consider, SGLT2 inhibitors, GLP-1 agonists, sulfonylureas, etc. There's a lot of other ones. Again, I'm going to make a separate video to go over those. But no, type 2 diabetes, unless they're in really bad shape, you're going to start with lifestyle changes, diet, exercise. If that fails, then go ahead and go to metformin. And then you have a bunch of other classes to consider. They're not going to say, you tried metformin and that failed. Now what class should you give them, and give you a bunch of options, because there's no right answer. They can't, you know, there's no second line really. It's anything after metformin, but metformin should always be your first line after lifestyle changes. One other thing I wanted to mention, I don't know if this is going to be so important for the boards, but in real life, there is something called, it's called LADA. It's latent autoimmune diabetes of adulthood, and you can actually see type 1 diabetes later on in adulthood. It's a later onset, and that's another thing that you should know of, just, you know, for real life and in practice. And that's pretty much it for type 2 diabetes. Again, I'm going to go into more in the actual medications, and that's going to be another video that I'll make later on. So a couple other things I think you should know about diabetes is diabetic ketoacidosis. This is a pretty big one. I could definitely see you getting a question on this on the boards or your EORs. So it's more common in type 1 diabetics because to be in a ketoacidosis, in that state, normally you have to be completely deficient of insulin. So it's not as common in type 2 diabetics for that reason. So most common in type 1 diabetics. As far as the etiologies, the way you're going to remember this is going to be the 5 I's. So the 5 I's stand for, the first one is by far the most common. That's going to be infection. That's going to be a patient with a UTI, pneumonia. By far and away, the most common cause of diabetic ketoacidosis is going to be infection. So it's going to be a type 1 diabetic, comes in, they have pneumonia, they have a UTI, they have some other type of infection, a septic patient, and they're going to be presenting with DKA. So as far as the other 5 I's, iatrogenic, steroids is a huge one. We see that all the time. And infarction is another big one. The patient may actually have an MI, they may have a CVA, and I could see that in a vignette too, where a patient comes in and they have chest pain, but then they have all these other symptoms, polyuria, polydipsia, altered mental status, and then you need to keep that in mind as well, as this patient may be in DKA. So remember that one. Ignorance, just non-compliance with their meds, they're not taking their insulin. And then finally, infant on board, pregnancy can cause diabetic ketoacidosis. So remember that, the 5 I's. If you're only going to remember one, though, remember infection, because that's the biggest one for DKA. As far as the presentation, patient is going to have nausea, vomiting, abdominal pain. Those are going to be your more common ones, of course, polyuria, polydipsia. The body's trying to get out all this extra glucose in the body. The body's acidotic. It's trying to flush out all of these toxins. On physical exam, one of the big ones is going to be the fruity or acetone breath. That's almost always going to be in a vignette when they're talking about DKA. You're gonna see fruity or acetone breath, and that's actually one of the primary ketone bodies that's generated in DKA causes actually acetone to be produced in the body, and that's why you're getting that smell from their breath. But that's really big. That's going to be, if they're asking about DKA, that's going to be in a vignette. Almost certainly. Small respirations, the body's trying to compensate. This patient's in metabolic acidosis, and the lungs are trying to compensate by having these deep respirations, this deep, heavy exhalation, trying to get out all of the CO2 that's in the body, all of the acidotic state. It's trying to compensate. So small respirations is another big one. And then the patient's also going to be dehydrated. So you're going to see they're going to be tachycardic. They're going to be tachypneic. So look for those things too in the physical exam. As far as diagnosis, their blood sugar is going to be elevated. It's normally over 250, but it's not going to be as high as in things like we see with HHS, which I'll talk about next. But the blood sugar, of course, is going to be elevated, and they're going to be in metabolic acidosis with a high anion gap. So you're going to see an arterial pH of less than 7.30. That's really important, and their bicarb is going to be less than 22. So remember that. This is one of the ones from I don't know if you know the mnemonic mud piles, but DKA is the D in mud piles for metabolic acidosis. This is one of the metabolic acidosis causes, the more common ones. Obviously, you're going to have positive ketones in the urine. Treatment. So the way you're going to remember treatment, this patient is dehydrated, so think of them taking sips of water, and that's the way I remember it, and I'll let you know what each one stands for. But remember, when you're thinking about DKA, treatment is going to be sips. They're really thirsty, they're really dehydrated, so think of sips of water. And then what SIPS stands for is going to be saline, insulin, potassium, and then search for an underlying cause. So breaking that down, the saline, you're going to start with isotonic at first. But once the blood sugar is less than 250, because you're going to be giving them insulin and you don't want them to go hypoglycemic, you're going to change to D5, dextrose 5% with the saline. So isotonic at first, then blood sugar drops below 250, change to dextrose. Insulin, you're going to of course give regular insulin. Remember, you don't want to be giving things like the Detamir and the Degludec, because it's a slow-acting insulin that works over 24 hours. You want to give the fast-acting insulin, so Lispro, Aspart. The only time you're not going to give insulin, you're going to give everybody saline. They're extremely dehydrated. Everyone's getting saline, but you may not give everybody insulin. Most people are going to get insulin, but if their potassium is less than 3.3, you don't want to give this person insulin, because remember, the treatment for hyperkalemia is actually insulin, because what does insulin do? It pushes the potassium into the cell. So you have somebody with a potassium less than 3.3, you give them insulin, all of the extracellular potassium goes into the cell. This person is going to become extremely hypokalemic. So insulin unless their potassium is less than 3.3, and then once you get the potassium above 3.3, you can start giving insulin, because you do need to bring the blood sugar down clearly, but not if their potassium is less than 3.3. So remember that. Potassium, again, is going to go to everybody unless at admission they're over 5.3. They have over 5.3 serum potassium, because obviously you don't want them to go in a hyperkalemic state. But remember, a lot of times this is actually going to be, the labs are going to kind of reveal this false, potassium, like a normal potassium state. Most patients in DKA, though, are going to be potassium deficient. And it's safe to assume that almost all DKA patients are total body potassium deficient. But if the labs are saying over 5.3, don't give them potassium until it's below this level. So there's a couple things to remember there. And then the S in SIPS is going to be search for an underlying cause, because remember, this doesn't just happen out of nowhere. Something's going on. They're having an MI, they have an infection. So figure out what else is going on that's causing this, so you can go ahead and treat that and prevent the problems that you're going to have with whatever the underlying cause is. So again, SIPS is going to be the way you remember it, but remember these little details, because that is important too. I don't think you're going to have to worry so much about this on the boards and exams, but it is important to know, especially if you're going to be working in an ER or somewhere. These are things that are important to know for real life, and is important. It's possible you might get one question on the boards or something related to this. So kind of remember SIPS, and then if you can, remember the details too. So moving on to HHS, hyperosmolar hyperglycemic state. This is going to be what you're going to see more common in type 2 diabetics. You're not going to see this in type 1 diabetics, because type 1 diabetics don't have the insulin to prevent. Type 1 diabetics don't have any insulin, so they're almost always going to go into DKA. You're not going to see this in type 1 diabetics. It's going to be more common in type 2. Again, nothing's 100%. It's possible to see it in either, but more common in type 2 diabetics. So the etiology, this is going to be a lot of overlap. It's going to be the same as in DKA. You can remember your 5 I's, infection, infarct. All of the same applies here. As far as the patho, so an illness, some other stress in the body, some stressful event is causing a lack of fluid intake, and this is going to lead to severe dehydration, which ultimately leads to increased serum osmolarity, hyperglycemia, and hypokalemia. As far as the presentation, again, the same as in DKA, except a lot of these patients are going to actually have altered mental status, which you won't see as commonly in DKA. A lot of the other same things, polyuria, polydipsia, nausea, vomiting, but more important for HHS, and a lot of times because these patients are older and they're extremely dehydrated, you may see altered mental status, which is more common in this pathology. As far as diagnosis, these patients normally have a much higher blood sugar at around over 600. Um, and these patients are actually, the mortality rate is much higher in HHS than it is in DKA. These patients are normally a lot sicker. Than the DKA patients. So their blood sugars are normally a lot higher than in DKA. Normally you're going to see over 600, increased serum osmolarity of over 320. And then the big one here, these patients are not going to be acidotic in most cases. Their pH is going to be normal. It's going to be over 7.30, where in DKA it's almost always less than 7.30. They're acidotic. So that's important to remember. Another thing that I wanted to mention with DKA is one of the important things to remember, especially when you're actually treating these patients in real life, is that the blood sugar seems to be the focus of most people, but the blood sugar isn't your main concern. It should be closing the anion gap. That's the most important thing when you're actually treating these patients in the ER. Your treatment isn't complete until you've actually closed that anion gap. That's the most important thing for treatment in DKA. So it doesn't matter if their blood sugar is 120, but they still have the wide anion gap. That's your most important treatment guideline for actually completion of treatment of DKA. So remember that. That's more for real life rather than the boards. So as far as treatment for HHS, again, same thing as in DKA, SIPs, saline, insulin, potassium, search for an underlying cause with the same stipulations as I mentioned before. So a lot of overlap here, but I wanted to make a chart to actually go over the differences, because I feel like if you kind of know this box right here, there's not a lot more that they can test you on. These are the important things to know. Outside of course, remember the presentation and the treatment, which is pretty easy with the SIPs, and then as far as the presentation, but remember these differences because this is how you're going to differentiate these patients. So in DKA, their blood sugar isn't always extremely high. It's normally over 250, but you're not normally going to see it in really, really high levels. That's more in HHS patients, though you're going to see over 600. The other big one, if you're not going to remember anything else, remember that DKA patients are almost always in an acidotic state. Metabolic acidosis, the pH is going to be less than 7.3, whereas HHS patients are not. They're normally their pH is normally normal. It's greater than 7.3, and a lot of times it can be within the normal range. So remember that. DKA is normally going to be a more acute presentation because remember these patients don't have any insulin. So when something happens in the body, this is going to be pretty dramatic and it's going to happen pretty quickly over maybe a few hours, maybe 24 hours, where HHS is a more insidious onset. These patients still have insulin on board. It's a lot slower in onset. It can happen over a few days or a couple weeks or so, whereas DKA is going to be more acute. DKA, again, is more common in type 1 diabetics. HHS is more common in type 2 diabetics. I've heard that really you can only develop DKA once you're at a point where you no longer even have a drop of insulin in the body. If you have a drop of insulin, you're going to be an HHS. Your body's not going to become that acidotic, basically breaking down the fats. That's what I've heard. That's the way I understand it, and that's why it's more common in type 2 diabetics, HHS, and DKA in type 1. DKA, you're going to see positive ketones always. HHS, you may have a small amount, a trace of ketones, and in some cases not at all. So these are the most important things to know. If you're going to forget everything else, remember that DKA, you're going to have this metabolic acidosis where whereas HHS is going to be a normal pH or even alkaline pH. So remember those. This is important for that. So that's pretty much all I wanted to touch on for diabetes. The next video, I'll go over the meds. I think that's really important, and I want to dedicate a video just to that. Again, go ahead and subscribe and like. I'm going to be coming out with new videos every week. I hope this is helping you guys. I know PA school is not easy. That was a rough 2.5 years of my life, and I hope I'm helping you in some way. And let me know what you think. Subscribe, like the videos, leave me a comment. Let me know that what I'm doing is helping you. It would certainly keep me motivated to keep these videos up. And that's it. I'll release the next video soon. I'm going to try to do the type 2 diabetes medications next.